Ladies and gentlemen, let me introduce you to our broadcast. This is Ask Your Doctors. This is an audience-based broadcast where we are going to spend the rest of our lives letting you ask us questions, and then the rest of that life finding experts to try and answer those questions as best they can. So welcome to Ask Your Doctors. I am Dr. K. I am a dentist by profession. Hopefully not for long, because it's very tiring. And I will be your regular host along with a few other of my colleagues. But today is a good treat because we begin with a bang, and we have Dr. Jazz Paddy, who is an interventional radiologist, a word which I had to practice many times before I could start broadcasting. And Doc, what's happening? How are you?
I'm good, but how are you, Dr. K?
I'm all right, thanks. I said I'm dentist, people understand what dentist is. So let's park that. What do you do, Doc?
All right. Yeah, as you have introduced me, I'm just known as Jazz mostly, but I'm Dr. Josiah Spuddy. So my work involves doing imaging of the body. It means taking pictures of the body using different equipment. And in that, those equipment, some are known as X-rays, others sonar, magnetic resonance imaging, fluoroscopy, those kind of things. We use that to get information from the body and then write reports as to where the problem could be when a person is sick. So most people are familiar with X-rays and scan, which they call a sonar. Others know a CT scan. So that's what I do. But more importantly than that, I don't only take pictures.
Let me just stop you there, Doc. Is that diagnosis?
That is diagnosis.
Okay, cool.
Right.
So school me, Doc. School me.
Yeah. So radiology is split into two. There's a diagnostic radiology and there's interventional radiology. So diagnostic is what I've just explained now, where we take pictures and write reports from those pictures, or graphs, radiographs, or whatever graphs that we come up with. The second part is intervening where there is a need. And the intervention will probably need you to tissue sample, to take a piece of tissue, send it to the lab for them to look at, or to treat. So that's interventional radiology. Literally, it's tissue sampling using the very same imaging, or to treat using.
Okay. Just in case everyone there wonders what we are all about, I said all questions health related. It doesn't have to do with dentistry. It doesn't have to do with what Dr. Paddy has just said to us. It has to do with everything, those included. So we're going to give you a chance. We have a lot of social media presence, and we have pages like Facebook, we have YouTube, which is one of the platforms where we'll be broadcasting some of our content. We have Twitter and the other pages, Instagram as well. And we will give you a chance to peruse through our content on our pages, formulate some questions that may be relevant to the topics that we are trying to guide you into, and then we'll come up with the answers that you're looking for. So anything health related goes. Yes, Doc. I started my career 25 years ago as a dentist. I'm a boy from Kwakwa. I hope I'm still a boy. Anyways, I feel that way. So, and I've practiced in Kwakwa for 17 years, qualified from vets, went back home, came back, and now I've been in Joburg for about 8 years. I'm mainly in Fourways, and now of late in Soweto, working in Midrand, and that's what I'm about. Okay, now tell us about yourself, Doc.
We almost have a similar, period of practice. Mine is 22 years. Born and bred in Pretoria. That's the town of Harankua. Did my undergrad medicine degree in Medical University of Southern Africa, now known as Sefako Makato University. From then on, then I went around, did my internship, community service in Limpopo, went around the hospitals, primary healthcare, regional healthcare, until I ended up in tertiary healthcare, where I did my radiology with vets, just like you. That's where I qualified to be a radiologist. Then I went on to do experiential training for interventional radiology with Vets Donald Gordon Medical Center. and that's where I acquired my stripes to do interventional radiology. And I've been practicing interventional radiology since about almost 5 years now, on the regular, both in public and in private, mostly in public than private. But as with you, my office is here in Fourways for interventional radiology private work. But I practice in other hospitals where I do the work, because here I don't do the work, I just consult. Yeah.
Okay. Well, when you thanks, Doc. That's a mouthful. And you do a lot of things, which is why it will be. Yeah. Tell me, when you do intervention, what's a typically most common procedure that you will perform? Because I know a little bit about what you do. I will learn more as we go along. Yeah. And but I want my my audience to say I was watching this program, and typically an interventional radiologist does boom. Okay,
so this actually takes us into a sneak peek of women health, which we will discuss later, I hope. Yeah. That's the most where most of our procedures are at the moment, especially in South Africa, where we treat fibroids, and we call that uterine fibroid embolization. That's where we draw most of our work, in complement with or in synergy with the gynecologists, where patients are not keen on surgery to remove the fibroids, or they've had the surgery and they don't want to redo the surgery, then they are referred to us to then embolize those fibroids.
Embolize, you mean?
We use minimally invasive ways of getting into the body. We use the vessels of the body, mostly arteries, to get to the womb. That's where we do the work of embolizing, meaning that we clot up the blood that supplies the fibroids, so that the fibroids don't get any feed of either hormones, nutrition, or oxygen, and then they start shrinking off and dying.
You choke them?
We literally choke them, deprive them of oxygen, yeah.
Okay.
And their nutrition. And then they shrink out, and they stop being active and stop causing problems. The problem with fibroids is that they are hectic with periods with women. The periods become too heavy, they become too regular, they become too painful, leads to back pain, leads to low abdominal pain, anxiety, depression, people cannot enjoy their social life as they should, or they cannot go on.
Their life enjoys, isn't it?
It's literally disrupted by abnormal periods or abnormal period pain.
Okay. Yeah. No, like I said, okay, that's a lot of information, a short space of time. And the show is only beginning. Yes. Imagine as we go forward.
And that was just a sneak peek.
Yes. Yeah, into women's health. That's a lot of, So guys, now you know what to expect.
Yeah.
We are going to feed you information, but also you must feed us questions, so that we don't just tell you what we must converse on. You must also tell us what bugs you, so that we get you all the experts that can help us sort out the myths in society. There's COVID around. One of these days we'll be discussing vaccines, a very favorite topic of ours, as well as everyone out there. We'll be debunking the myths around that. In future, we'll be discussing any and everything.
Yes.
But, Doc, this is November. Some call it Movember.
Movember.
I'm not an expert on Movember, except they say you keep a mustache until the end of November. People try to raise awareness around
main issues, main health issues.
Yeah.
Yeah.
Okay. Do you have any input regarding the social things that people are doing out there? Do you know any campaigns that you?
Yeah, actually, Movember has become more of it started off as a social media fad. People just say Movember, let's address main issues, to actually a movement now, where people have really gotten their teeth into mental health issues, because they've come to realize that men are the least and the last considered when it comes to campaigning for health. And part of it is due to men themselves, but the rest of it is that there are so many other campaigns that have already taken place that people are so used to.
And they have momentum.
They have momentum.
Yeah.
And that now we become the backbenchers in the health aspect. But that is quickly changing, and it needs to change.
Because of people like us, among other things.
Of course. Yeah. And we need to push that forward and make sure that it runs together with all other programs, so that then it is a complete and wholesome attack on health issues that affect humans, not just certain types of humans, that all humans are then addressed in this regard. Okay. So social media movements, the campaigns, your normal analog radios, your digital radios, advertisements, NGOs, government organizations as well, trying to push men's health forward, because it has become, sorry to use the word, pandemic for men not to consult on health issues, which is a problem. And we are in a pandemic of a different nature. Yeah. And
we are fortunate that we already have some of these confessions from some of our viewers that have gone onto our socials and picked up the topics that we were going to be talking about, and they were very interested in this one. And now and then we will go back to their questions and just voice out their concerns and stuff. And Doc, we looking at a few topics regarding this men's health thing.
Yes.
We're going to talk about the psychosocial dynamics, what's going on in society.
Yes.
And then we're going to talk about the physical well-being of men. And we will not be handling this, we won't handle this adequately unless we go to the sexuality of men.
Yes.
That has to do with their health.
Yes.
And it looks like the sexuality is a big thing when a man is unhealthy. But the thing is, we are even afraid to look after our health or have it checked. So we are in a spiral here, vicious cycle.
Yes.
So yeah, guys, we will handle your questions, and thanks for joining us. We will be entertaining your questions as they come in. We will encourage you even for future topics to give us questions.
We would like them to actually suggest, because men's health is a big animal. You can compare it to an elephant, from the tusk to the tail, and we cannot handle it in one sitting. We will need to take it piecemeal to give it value, to give it impact, and for it to be effective and make it relatable as well. So today we may not do justice, but we will try and do justice to those questions that have been asked today.
You're talking about the tail. I'm going to ask you a question from one of our audience members. Because I don't want to talk about the tusk. You see what I did there?
Yes.
The teeth? Yeah.
So you're taking it.
So we won't talk there. Let's start with the tail, Doc.
Yeah.
There's a question that says, my doc says it is advisable that I must go for a colonoscopy.
Yes.
I'm scared to bits about it. That's one of the questions. And we spoke before about this, and you said it's actually advisable for the guy to listen to their doctor.
Yes. So it's there are certain diseases that are age dependent, and the older you get, the more they become a reality more than a risk. So for you to know that you have a chance of having something, we call it a screening. Sometimes you need to screen for it. Colonoscopy has actually become more of a screening than a diagnostic test that we do for men, to try and see if they are not coming up with other diseases that once are there, they'll be very difficult to treat. So we want to try and see if we can, stem them right at the beginning, than attend to them when it is late.
What is colonoscopy?
Yeah, I think doctors like difficult words, but colonoscopy literally talks about looking inside your bowels, right?
Through the tail, though.
Yeah.
Because there's another one.
We come from behind,
okay.
And look at your bowels from behind. Then colonoscopy literally means looking at your big bowels, because you've got big bowels and you've got small bowels. In medicine, we call them large and small.
Intestines. Yes.
Right, intestines. So we look at your large intestines through a camera that's put from the back, and it's sent up to look at how the whole structure of your large bowels look. And if there are any problems there, that may indicate that there's the beginning of a, deadly disease, things like cancer, that we would want to pick up very early, because once we pick it up very early, then the treatment of it becomes easy or manageable. And if we pick it up more advanced, then it becomes much more difficult, much more complicated, and much more expensive. And the complications after treatment are even sometimes worse than the disease itself. So colonoscopy is just to go look inside your bowels with the camera to see if it is normal, one. If it is normal, what is abnormal? Is it something that we can treat? We call it benign. If it is abnormal, it is something that we can treat, but it is still malignant. Malignant, it means it's cancerous. Or it's gotten to a point where maybe we can just try and rescue the situation where we find it. Yeah.
So you've handled colon cancer in your explanation, your definition of colonoscopy and what it does. And two things come to me. Polyps are something spoken of when it comes to colonoscopies. Are those an early indication of something that is treatable? I believe they are found quite a lot.
Yes. So polyps, there are two bits of them. There's one that I talked about, benign, meaning that they are not cancerous. Those are the ones that they bleed. They tend to bleed and cause trouble. Then they are treated, removed. And then there are those ones who have now become cancerous. And those two, depending when they are found, if they are found early on, they still can be treated either just with surgery, or surgery meaning removal only, or surgery with anti-cancer treatment. We call it chemotherapy.
In a way, Doc, you mentioned blood. From a layman point of view, if I see blood in my stools, I cannot self-diagnose.
Yes.
I should just know that it is something worth checking.
Yes.
And if my doctor suggests a colonoscopy, which is coming from behind where the blood comes from and looking in, it's trying to see if it can be treated early. So don't be scared. It's not that deep. We just looking for ways to conscientize the public to say, go early, have it checked. There's nothing wrong with men going through a colonoscopy.
Early detection is key with every disease, no matter how small or big. Early detection is always key. We always encourage people to go in early for either screening or early diagnosis.
Okay. This is about the physical well-being of men.
Yes.
Okay. Let's transition from there. While we are there, let's talk about the prostate, because I believe these are interrelated in terms of the way they are checked sometimes.
Yes.
You may not use a colonoscopy all the time to check for prostate cancer, but as part of the physical well-being, when doctors go down there, what are they looking for?
Okay. So prostate is a gland that you find at the base of your bladder. And it is part responsible for your reproductive health, because that's where you get chemicals that help.
Hormones, is it?
We call them prostaglandins.
Okay, cool.
Elements, and they help your spermatozoa, your sperms, to become more effective, because for you to be able to fertilize an ovum, you need something that will help the sperm pierce through the wall of the ovum and then interact with the ovum. And it has to carry, so you carry those things in semen. So the sperm come from the testes, which we'll talk about it at some point, and the prostaglandins come from the prostate and through the semen. So the sperm comes through the semen, and with the semen, they carry through the urethra, out of the urethra into the vaginal vault, out of the vaginal vault into the mouth of the uterus, the cervix, then goes into the fallopian tubes, where they might meet an egg to fertilize during an act of trying at pregnancy, which is unprotected sex.
So two things about the prostate.
Yeah.
That's where baby prostate gets involved in baby daddy stories,
Yes.
and prostate gets involved in cancer. That's the
Yes.
one people want to know more about.
Right. But before cancer, the one problematic thing for men, it's not really cancer with the prostate, but it is the enlargement of the prostate itself, which can cause problems.
The benign something.
Right. We call it benign prostate hyperplasia
Okay.
or benign prostate hypertrophy,
Okay.
meaning that it has become large. Benign, we said it before, non-cancerous. So when you hear the word benign, you mean non-cancerous.
So it's still treatable, guys.
It is still treatable.
benign.
Right. Prostate is the gland itself. Hypertrophy is the overgrowth thereof.
Okay.
Right. That is the biggest problem in men, to be honest, more than the cancer.
Okay.
Right. Then we'll come to the cancer. So that's the one that men need to consult for initially. So at the age of 45 going up, actually they want to bring it down to 40, but at the age of 45 going up, all men without exclusion need to go for a prostate exam. And that is usually done by a urologist.
Okay.
And it is called a digital exam, meaning that a finger is used.
Digital means no invasion. Eh?
It means no. Digital.
It's digital.
Digital in this case is not your normal
It's not the one I'm looking for.
IR, IT kind of stuff. No, digital, it means a finger,
Okay.
right? And they call it the digital exam. And that digital exam, it's a finger, and usually it's the index finger. It's put through your anus, and just immediately after your anus, it's pointed forward and feels for your prostate, because the prostate lies right anterior to your rectum. So we come in through your anus, stay at your rectum, here's the prostate, and then it is felt all round. So we feel for smoothness, we feel for overgrowth, we feel for nodularity, we feel for things that may be poking out like calcifications, things like that, things that are not healthy, right?
Okay.
And we also feel for pain, because you're not supposed to feel pain when the urologist does that.
You're not supposed to feel pain.
You're not supposed to feel
If
pain.
someone is generally uncomfortable with the procedure being done,
Discomfort is not pain.
okay.
So we have to differentiate between the two. But you're not supposed to feel pain. So
Okay.
let's just finish this one about the prostate examination. And once the urologist comes out, says, okay, fine, I think your prostate is fine, then it's done. It's finished. And unfortunately, that's where men have difficulty.
Okay.
The thought of a finger going up their anus into their rectum to feel for the prostate. As to why men have a problem with that in particular, I myself don't know. I feel like men should then start getting used to certain things, because women go through certain things that they're not comfortable with.
Personally, Doc, I know I am over 40.
Yes.
Slightly over 40, hopefully.
Yeah.
I will get it done
Yes.
for myself. Probably in the month of November.
Yes.
Okay, fine. But there's another, it's not an alternative treatment.
Yeah.
It is an add-on that is more, that is kinder. So I'll do
Friendlier.
both. That is
Friendlier.
friendlier, more user-friendly, where I give blood and I get my results. I'll do both because you say I must do both, right?
Yes.
Is that what you're saying?
Yes. I think in trying to look at problems of the prostate, we don't do just one exam. We do a digital exam, and there's what you call an imaging exam. This is ultrasound,
Okay.
right? Then after that, then we do a lab exam.
Okay.
That is where we take blood to look at. There's a PSA
Okay.
that we look at, and then the levels of which tell us whether it is normal, whether it is overgrown, or whether it is cancerous. The highest it is, the more likely that it is cancerous. The in between it is, the more likely that it has overgrown. The less it is, the less likely that it is overgrown, nor is it cancerous.
Okay.
So that's the one that we're talking about, the blood test.
What is it called again?
PSA,
What does that stand for?
Prostate-Specific Antigen.
Okay, cool.
Right, that's what we look for. Right. Then on ultrasound, we look at the structure of the prostate, we look at the center of the prostate, we look at the periphery, the surrounding of the prostate, we look at the wall of the prostate, we look at what it's doing in its on its surrounding structures, which is the bladder, because like I said, it sits right at the base of the bladder. And the reason it sits there is because, remember I told you, like, the urethra goes through it. And the reason the urethra needs to go through it is because there are tubules that come into the urethra via the prostate. We call them seminal vesicles. Yes. And these seminal vesicles are the ones that carry your sperm. Okay. Right? And once they are in there, then the prostate gives them the semen with the prostaglandins, then they are complete. Then they are ready to go and try and meet a friend and socialize with the ovum and then penetrate so that then we can have conception.
You said urethra. Another problem that we should not overlook is when I'm home and I am finding it difficult to wee. Does this mean that the urethra is affected in any way? Sometimes by I'm not self-diagnosing. Yeah. I'm saying it could be the difficulty with urinating might mean your prostate is enlarged, but don't self-diagnose. Have it checked. Is it possible?
Hence, I said the biggest problem with prostate is not the cancer, but it is the overgrowing. So when it overgrows outward and inwards. The outward is just bulking out. The inwards is where the problem is, because it closes down the opening of the urethra. The more it closes down, the less urine you are able to pass through, the less forceful it is. Then it starts dribbling. The more urine you have remaining in your bladder after going to urinate, the more problematic it is, because anything that remains there is perfect ground. Perfect ground for infection. Right? So
inside the urethra?
No, inside the bladder.
Okay, cool.
Right, it creates that problem. Now, once we've got bladder infection, how we diagnose it, we say we've got lower urinary tract symptoms. What are those ones? You get urgency. It means even if there's a small amount of urine in your bladder, you want to run to the bathroom. When you get there, it's just a little wee. You get frequency. It means you go very often. So urgency pushes you to go, frequency it says often. Right? You get burning. Right? Or urine burns. And it is accompanied by blood. We call it hematuria. Right? Because now the walls of the bladder are getting affected and sloughing off, and then because there's small blood vessels that feed there, then they start seeping into your urine, and usually the blood comes right there at the end of your urination. That's how you know that there is a problem with your bladder. When blood comes right at the beginning of your urination, the problem is either in the urethra itself or it's throughout the entire system.
Yeah. And Doc, you just to go back, the enlargement of prostate can actually cause you to retain urine.
Yes.
Untowardly, meaning you're supposed to urinate, but you're not urinating properly. And just to go back even further, just to recap for the audience, this enlargement of the prostate doesn't necessarily have to happen because there's a big reason. It can happen because we are just at that age. You said they are age specific.
It's an age-related condition. So we call it a condition and not a disease, right? Because there are conditions that we develop as we get older. That's how we just are as human beings. And because it develops at a certain age, we need to do that screening at that age, mostly at 45, from the ages of 45 yearly until our last day on earth.
So with or without symptoms, I just need to have these things checked.
You just need to have them checked.
Because I tell you what, psychosocially, socially, to be specific, guys just laugh at each other to say you dribble when you urinate.
Yes.
It means you're old. But that doesn't mean you shouldn't investigate.
Yes.
Because it might have other implications that we overlook.
Yeah. You'd have to understand the psyche, and I like that you want to look at it more both from the social, medical, and the psychological point of view. The psyche of men is to always downplay problems because they are afraid.
Especially if they affect our male.
Exactly. So if we are same age and you've got a problem, I will downplay it as a man because I'm afraid that might be the issue with me later. Right? So fear plays a big role when it regards health issues, when it regards to men. So we tend to make jokes about things that are very serious. But if your friend is dribbling and confesses that he's been dribbling, or you've seen that he's dribbling, the best way to advise would be to say, please go seek help, because dribbling is never good. the stream has to flow. You know, if it's a powerful stream and it's flowing and it can overshoot to the distance, then it's a healthy prostate, usually. Usually it's a healthy prostate. But once you start having, you know, distancing, that's how they say you should measure your life as a man. The shorter the distance you are able to shoot your pee, the shorter your life is likely to be. The longer the distance you are able to shoot your pee, it means the more likely that you'll live longer. So you'll see with the young men, you know, teenagers, you know, they even compete about it. Let's see how far I can shoot mine. You know, that's health. Men, we don't compete about how far because we know we'll be embarrassed. Yeah. So that's one of the reasons. Part of the other reasons of measuring men's health is they say the more add-on holes you put on your belt, the less your life becomes. So if you keep the same holes, chances are you're not gaining weight, you know, things are going well, you're not having an abdominal girth increasing, so it means that things are still well. But the more you increase the number of holes so that you can move the, you know, the lock back, the less your life is likely to be because of lifestyle issues that may emanate from that. And
the way you're talking, Doc, you're making it sound fun to talk about. Yes. Because, you know, these are things that as lay people we can remember.
Yeah.
And let's not be shy to read up about these things wherever and have these conversations at the bar. You never know which one of your friends would take the advice and actually go to see a urologist.
Yes.
You said a urologist can also do an ultrasound if maybe.
Yeah, they do ultrasounds, but they do ultrasounds especially for the kidneys.
Yes.
They may do ultrasound for the prostate, but mostly it's a It's an ambit of radiology.
Okay.
The imaging part is mostly done by radiologists.
Okay.
Theirs is mostly to do the digital exam and the blood tests and interpret the blood tests.
Okay. And another thing, we may only be talking about it today, but this is not the only time to be doing your exam. I want us to catch a break, Doc. And when we come back, we will talk about the psychosocial dynamics of. We're going to talk about things like black text, how it's affecting us as men.
Yes.
If we have time, we can even talk about whether or not. I'll probably just ask you honest opinion on Lobola, but just prepare yourself.
No, let's do
a short answer. You don't have to commit yourself. And then we're also going to talk about things like we're going to entertain some of our questions from our viewers that come from social media. And by the way, that's the best place to give us your questions. Yeah, and
I believe the audience needs a break from us because you're saying I've been saying a mouthful. So Machita can go and grab a glass of their favorite toxin, not too much, or water or whatever. Come back and sit with us. Let's have an idle conversation about ourselves. Without fear, you know, without ridicule, you know, in our private spaces. But also, if you're interested, please send us the questions. We'll ask them as best we can. And where we fail, we will call in the very experts that we mention every time we mention diseases.
And your examinations can be done all year long. It doesn't have to be in November.
They are called routine.
Maybe you gather your guts next month. Do it January, New Year's resolutions.
Do it as your birthday gift. Do it routine. Every time on your birthday, do your general examination, do your prostate check, especially if you are over the age of 45. You know, do your colonoscopy. You know, you'll come back with a clean certificate. That's the best birthday gift you can give yourself, you know, and encourage your friends to do the same.
Cool. Thanks, Doc.
All right, man.
Yep. All right, Doc, you good?
I'm good, man.
Okay. Guys, welcome back to our continuing discussion on men's health issues this November or Movember. And we are now continuing to discuss the physical well-being of a man, where we talk about the health of male organs generally. Later on, we need to go into the psychosocial and other related mental health, so on, issues to do with the overall health of men. Doc, regarding, I would like us to touch on two issues. One is cancer. Let's say we couldn't detect anything benign that could be treated, and it's a bit late, and now we're talking cancer. Please take us a little bit A and a little bit to Z of.
Okay. So yeah, other than the enlargement of the prostate, then we have prostate cancer. I would say, for lack of a better word, the nice thing about prostate cancer is that it's a very slow cancer, very slow. So if we detect it early, it can be treated with success very early, right? But if it's treated late, it's found out late, it can be very debilitating because it goes everywhere, and especially the bones of a man, where it makes it difficult for him to actually carry out his normal functions. So cancer is an abnormal overgrowth of the cells that were there, that have now been affected and deformed, and they grow so much so that they take over the organ where they are found. And because they take over that organ, they take over everything that is surrounding. And once they've taken over everything that is surrounding, then they get into the blood system, and then they are moved to other parts of the body. It can be your lungs, it can be your liver, your kidney, everywhere, and until the brain. So we don't want it to get to that point. So that's why we say early detection is key. The early we screen for the cancer, the better it is for every man, and that's why routine checkups every year after the age of 45, or from the age of 45 going forward until your last day on earth, are important. Right? The treatments are less complicated at early stage and more complicated at late stage, even with chemotherapy.
So it's not all about the knife.
No. Even with chemotherapy, it is normal chemotherapy drugs that are used at an early stage, which are effective, but at a late stage, we have to change them. Some of them are not even in our books in the Medical Control Council. They need to be motivated for, and they are specially couriered for you. Sometimes medical aids may have issues with them. So we need to engage more and more expensive, much more complicated treatment. So the better, I still will say, early detection, early treatment is key. So then there's removal, which is surgery, and can be either done with open surgery. It means they open you up right at the base of the bladder, they take out the entire prostate, or they can do laparoscopic. Laparoscopic, it means it actually, they don't open you up, they just use cameras and lenses to perform the surgery. The one that is done is they can come through your urethra. They call it transurethral prostate removal or resection, TURP, resection of the prostate, and then they are just come through and then they cut it out. That is for usually for cancer. For the enlargement, it is still the same processes without chemotherapy, either open surgery or minimally invasive surgery through the urethra, or you can use interventional radiology where we do prostate artery embolization, same as we treat for fibroids. We close up the blood supply and choke the prostate of its blood supply, make sure that it comes down from the size, the overgrown size, to a small size.
How popular is the last one?
The prostate artery embolization, it is the most latest, the most modern, not so popular with so many people, but it works. And it's still a work in progress, because usually medicine is practiced in a traditional way, and people still use traditional ways of doing it. But the more we make inroads and development and evolve with medicine, the more new ways are taken up and it has become a little more popular than it was before, and it is growing. And that is what interventional radiologists do. Others are done by urologists. Prostate artery embolization, where we stuff the prostate of the blood supply, but that's when there's no cancer, right? And then the other one is actually putting therapeutic radiation beads within the prostate to make sure that they emit the radiation that treats the prostate. If you remember, our former president had prostate cancer and was treated. Our emeritus has had prostate cancer. He is the longest living patient that has been treated successfully and recovered from prostate cancer. And our emeritus bishop. and still alive even today. He was celebrating his birthday not so long ago, and he's the voice for South Africa, and represents human rights and
So he deserves the years that he's getting.
through that,
the
advocate for justice all over the world. Okay. So those are the ways we would look at treating prostate cancer or benign prostate hyperplasia. When there's no cancer, it's prostate artery embolization. When there is cancer, it's all other things that I have mentioned before.
One of the questions we get from our viewers is about impotence.
Yes.
And is there treatment for it? I believe it's also a condition, not a disease, is it?
Right. So impotence is a condition, but it's a condition that exhibits problems elsewhere.
Okay.
Usually it's not a local problem.
Okay.
Most of the time when a person has what we call erectile dysfunction, it is not usually a local problem. It is either a systemic problem, right, meaning that the body is diseased, okay, right? It is usually a psychosocial problem. It means that there are issues outside the body that affect the mind, and the mind cannot then work together with the body organs to effect certain processes like an erection, right? Or it can be a local problem. If it is a local problem, it's usually from prostate hyperplasia, the overgrowth thereof, or it can be from prostate cancer itself, right? When we treat it with the prostate artery embolization, we want to, especially for the enlargement, we want to preserve your erectile function. Okay. With surgery, sometimes it is difficult to preserve the erectile function. So we just treat it because it's causing much more trouble than it's necessary. And impotence in itself, which is erectile dysfunction, is a big problem for men because it questions their manhood. And that's where the psychosocial aspect that we're talking about come in.
And sometimes, just because a guy suspects certain things, which is manhood, it can affect them psychologically so much that it actually becomes another problem.
Yes, it becomes another problem and leads to other issues in terms of emotions, in terms of their psychology, in terms of their interpersonal relationships at home and outside, and also in terms of the belief systems. Because the men who still believe that the reason they cannot get an erection is because they slept with a woman who was unclean, one. Or that woman was trying to take over their manhood or deprive them of their manhood, two. Or try to cause problems at home, especially if it's an extramarital or extra relationship affair. So that's how men tend to think about. So these myths around erectile dysfunction go far beyond the psychosocial, the emotional, and the physical. They go into belief systems and traditional beliefs, and they are then meshed into how we live our lives, especially as Africans, and they can create real big problems. So they need to be addressed.
While on impotence and erectile dysfunction, I would like us to entertain a question from one of our viewers. It says, I drink and have fun every weekend. And one day I wanted to have fun with a girl I met, but I wasn't aroused. Do I have erectile dysfunction? Let me ask it in a different way. Yes. I know you've got that one, you will answer the yes. Now, does alcohol lead to impotence?
Without a doubt. And I will say that and not even flinch. Because alcohol in itself has so many other effects on the body that we are not even aware of as men, right? And some of them are immediate, others are long-term, right? So depending on how much alcohol you take, sometimes even with the binging, sometimes it's constant, other times most people binge, they drink on weekends only, but they drink a lot of alcohol, which affects how they function. And other people are just dependent on alcohol for function, and it affects how they work. So alcohol affects a lot of systems in your body in a nutshell, and these systems are important in your erectile function, right? So if you took too much alcohol, like the gentleman is saying, it could be that the mind is so out of it and so depressed.
He does it regularly,
yeah,
he says.
Right. That okay, let's just talk about the acute setting where the mind is so out of it, so depressed that you can't actually direct with your mind.
But I've heard social people say alcohol makes men stronger on the day.
It depends. In moderation. In moderation, it takes away the anxiety.
Okay.
The more disinhibited people are, within moderation, the more they're able to engage socially.
Okay.
So alcohol as a disinhibitor of social interaction is good in the sense that some people are shy and introverted. But once they have a bit of alcohol, they can engage. They can go to a woman and talk and, create an environment that creates likeness, and likeness creates other avenues of a relationship and later on sexual intercourse. However, alcohol, when taken in very huge amounts, or what you call copious amounts, can do the person that was introverted can be too extroverted that they become disruptive. And that in itself creates other social problems. But if you take alcohol for a very long time, then it toys with your liver functions or your enzymes. And some of these enzymes are important in the function of in the functions of erection. So later on, when you have severe liver disease, you are unable to get an erection. Why? Because the hormones that are supposed to be playing a role,
Okay.
in your erections are now have been compromised, right? And then the brain cells as well are not working as well to help you achieve the required erection. Okay. So it could have been that. It could be that the hormones are affected.
You groove because you socialize, and when you socialize, you can get a partner or what. But the same habits that you engage in when you groove, like drinking a lot, can actually kill your long-term chances with this partner.
Yes.
In terms of intimacy and all that.
Right. So those we call lifestyle diseases: alcoholism or increased alcohol intake, your diet that is not controlled, lack of exercise, not treating your conditions like hypertension and diabetes. These two themselves as well create a conducive environment for you to have erectile dysfunction.
Sure. It's a lot to take in. Remember, I'm a man as well, and I'm over 40. Anyway, one last question from one of our viewers, and then we'll wrap it there, and then we'll give enough time to the other elements, which is the psychosocial, and actually just the psychosocial aspects of men's health, and also just mental health.
True.
But for now, let's handle this one is about alcohol. We went through that one. I think we've got all of them because this one duplicates itself. The other one is about black text, but I suppose that has to do with mental health and the psychosocial dynamics. So those
we'll tackle when we tackle the psychosocial issues that affect men's function and men's health.
Okay, cool.
Right. So I think it's, just to wrap it up, it's important that we men start having different conversations with each other. The younger the better. So we are then freer later to talk about it. Because if we stigmatize dysfunction in men, right, premature ejaculation, no erection, sometimes people think it's normal to have an erection for a very long time, but that is abnormal. We call it priapism, and it could be due to other diseases within you that you're not aware of. So the minute you have an erection that does not go down and it's painful and goes on for hours, more than an hour, more than 4 hours, we call that priapism. That is a problem in itself. It's not manhood. You're not strong. There's a problem somewhere in the body which you need to go get checked out. So erectile dysfunction, in terms of no erection, premature ejaculation, priapism, too long an erection and painful, and all other issues related to our manhood should be discussed freely in a free setting without judgment, as we are joking with each other, but attending to the issues and giving a safe space to all men, ourselves, to say, let's talk about these issues, how do we attend to them, who are you going to see, who needs to be consulted, and all of that.
Look after your health. That's basically what you say. Don't eat right, you eat right, exercise. Don't drink too much.
Yes.
And
if you are diagnosed with diseases that are chronic, like diabetes and hypertension, take your treatment, don't skip your doses, and go for your regular checks. Make sure that you are controlled. Once you are controlled, everything is fine, because then it attends to your other extra physical nature, which is the psychosocial.
Okay, guys, I think we have it. Thanks, Doc. Let me take myself out of the picture. There we have it, ladies and gentlemen. This is Ask Your Doctors, and please always go to our socials to try and give us questions. You see, we have time for your questions. And because this is early days, we may not have a lot of questions from you, but we expect you to go to the socials and flood us with your questions. It's Ask Your Doctors on all social media platforms.
Yes.
Thank you very much.
Do ask your doctors and get the answers that you need from the experts. If it's not us, it will be the ones that we will have invited. Thank you, Dr. K. Thank you to the audience.